Good morning, everyone. Myself, Dr. Devangi Dwivedi. Today, I'll tell you about skin disease, pemphigus. So, pemphigus is a serious chronic skin disease. It's characterized by the appearance of vesicles and bullae, small or large fluid-filled blisters that develop in cycles. It is derived from Greek word pemphigus, meaning bubble or blister. Pemphigus describes a group of chronic bullous diseases originally named by Wickham in 1791. There are three subtypes. They are named accordingly as Pemphigus vulgaris. We also call it in short as PV, Pemphigus foliaceus, and lastly we have paraneoplastic pemphigus. Each type of pemphigus has distinct clinical and immunopathologic features. First, let's take up Pemphigus vulgaris. Pemphigus vulgaris is an autoimmune intraepithelial blistering disease affecting the skin and mucous membranes and is mediated by circulating autoantibodies directed against keratinocyte cell surfaces. Clinical and experimental observations indicate that the circulating autoantibodies are pathogenic and immunogenetic predisposition is well established. Blisters and PV are associated with the binding of IgG autoantibodies to keratinocyte cell surface molecules. These intercellular or PV antibodies bind to keratinocyte desmosome and to desmosome-free areas of the keratinocyte cell membrane. We all know desmosome is the epithelium to epithelium connection. The binding of autoantibodies results in a loss of cell-to-cell adhesion. Intercellular adhesion in the epidermis involves several keratinocyte cell surface molecules. Pemphigus antibody binds to keratinocyte cell surface molecule desmoglein 1 and desmoglein 3. So these names have to be remembered, desmoglein 1 and desmoglein 3. Patient with the active disease have circulating and tissue-bound autoantibodies of both the immunoglobulin G1 and G4 subclasses. Disease activity correlates with antibody titer in most patients. Pemphigus antibody fixes complement to the surface of epidermal cells. Antibody binding may activate complement with the release of inflammatory mediators and recruitment of activated T cells. Now coming to the clinical features. So the mean age of onset is approximately 50 to 60 years and it is characterized by the rapid appearance of vesicles and bullae varying in diameter from a few millimeter to several centimeter in such numbers that large areas of the skin surface may be covered. These lesions contain a thin watery fluid shortly after development, but this may soon become purulent or sanguineous when the bullae rupture. They leave a raw eroded surface identical with that seen when focal areas of epithelium slide off either under oblique pressure or spontaneously without the prior formation of a vesicle or bullae. Here we can see the clinical photo. Next, coming to the Nikolsky sign. This is a very important feature, or you can say the striking feature of pemphigus. The loss of epithelium occasioned by rubbing apparently unaffected skin is termed Nikolsky sign. It is characteristic feature of pemphigus and is caused by perivascular edema, which disrupts the dermal epidermal junction. Next, let's take up the histologic features. So it is an entity which is characterized by the formation of a vesicle or bullae entirely intraepithelially just above the basal layer, producing the distinctive supra-basilar split. Perivascular edema appears to weaken this junction and the intercellular bridges between the epithelial cells disappear. This results in loss of cohesiveness or acantholysis, and result of this, clumps of epithelial cells are often found lying free within the vesicular space. These are known as Zhang cells and they are characterized by degenerative changes which may include swelling of the nuclei and hyperchromatic staining. Here we can see the histopathological picture. There is intraepithelial separation or suprabasilar splitting. These are the gland cells which undergo the degenerative changes. Then mild inflammatory cell inflammation is also seen, and this is whole thing is the connective tissue stroma. Next, let's take up Pemphigus foliaceus. So it's generally a benign variety of Pemphigus. It is an autoimmune skin disorder characterized by the loss of intercellular adhesion of keratinocytes in the upper parts of the epidermis, resulting in the formation of superficial blisters. It shows the clinical involvement of healthy appearing skin that blisters when red. As I've already told you about the Nikolsky sign, Pemphigus foliaceus is characterized by a chronic course with little or no involvement of the mucous membrane. Superficial blisters in PF are induced by immunoglobulin IgG, and also here desmoglein 1 is involved. Precipitating factors include medications and ultraviolet light radiation. It was recently suggested that both factors enhanced autoantibody epidermal binding and preferential neutrophil addition to UV radiation epidermis, which contribute to acantholysis in photoinduced PF. Next, coming to Pemphigus foliaceus clinical features, is manifested by characteristic early bullous lesions which rapidly rupture and dry to leave masses of plaques or scales suggestive of an exfoliative dermatitis or eczema. The disease may originate in this form or may develop from one of the other types of Pemphigus. It is a relatively mild form of Pemphigus, which is most common in older adults, but may occur in young children as well.